Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN. Healthy you, healthy nation, healthy world. I'm Nancy Valentine, PhD and registered nurse. And I'm here for you, bringing you some wonderful guests to talk about different topics that are really going to help inform you about your healthcare decisions and assist you in being healthier, you, your family, your friends. This evening we have a very interesting topic entitled Emancipation Proclamation, How Patients and Families, that's you, can take leadership for your care. Now that's a pretty heady topic because when you think about who takes responsibility for your care, most of us are usually willing to turn that over to our physicians or other treatment team members. But things are changing, and as we are more involved in our health care, we want to take part in this. We want to have a really viable role. So what is going on is really a cultural transformation. That is what is really referred to in healthcare these days. That we are moving away from just the doctor being in charge to really the cultural transformation of really having a team approach and we taking a leadership role for ourselves. And that's what we're going to be talking about this evening. And in order to really use the exemplar that we have 2 guests that I will introduce in a moment. But just as President Lincoln said, you know, and that's a very popular movie, as you know right now, and that whole discussion about the Emancipation Proclamation, it wasn't particularly popular when President Lincoln introduced it at first, and it is a transition for our whole healthcare world right now. But it is a moral force. It's something that is really making a difference in the quality of people's lives. Mm-hmm. And recently, President Obama, with the healthcare laws that are changing, did in April of 2010 mention as part of that whole long healthcare reform law is that people are to receive compassionate care and equal treatment during their hospital stays. So the question is, how do we make that real? And that's what we're going to talk about tonight, because it is real and our guests have really made that a reality. Now, this is not a nursing initiative, even though our guests are 2 excellent nurses who have a great deal of experience in the field. This is a team sport, and they will talk about how they got other professional people involved in this as well. So let me introduce our 2 guests this evening. I'm happy to have my friend and colleague, Dr. Victoria Rich, with us. Victoria is the Chief Nurse Executive at the University of Pennsylvania Medical Center. She's also the Associate Executive Director of the Hospital of the University of Pennsylvania, and she plays a key leadership role in the School of Nursing at the University of Pennsylvania, one of the top nursing schools in the country. Victoria is recognized for her leadership in healthcare, business, and nursing education. She is most noted for her pioneering work in patient safety and cultural diversity. So through her many aspects of care leadership and management, she devised this plan of how to really make Emancipation Proclamation for you, the patient, a reality. But she needed a partner in that. So she was wise enough to bring our other colleague, Mary Walton, into the picture. Mary is a master's prepared nurse, and she has a degree as a nurse ethicist. And her title at the Hospital of the University of Pennsylvania is that she is the nurse ethicist and director of patient and family-centered care. And it's the patient and family-centered care that we're going to be focusing on. She has 35 years experience. She has lectured extensively on this topic, and she has been able to bring this program to a reality. So with that in mind, let's welcome our 2 guests, Victoria and Mary, and they are going to tell us how they made Emancipation Proclamation happen at the University of Pennsylvania Hospital.
Well, Nancy, we are delighted to be here, and that terminology perhaps might be a little controversial for many people, but as Nancy knows me and I know Nancy, we are both, I would say, fairly provocative in what we're trying to talk about, and of course I have in my partnership with Mary the same way. And from our backgrounds as being nurses, and really with the Gallup polls continuing year after year, showing that the nursing profession is still the #1 most trusted profession. And really, my sense is, why do our public say that over and over again? It's because we have the candor and the transparency to always look at what the patient and family needs. And our vision is always, what's going to happen to you once you go home? I'm going to be concerned about you. I'm going to be worried about you. And so our profession has always continued to do that. But what we are looking at, particularly, I would say, Mary, over the last 10 years, is really, even though we realize that, it's always been more healthcare focused, of what the nurse needs, the physician, what the respiratory therapist needs, the pharmacist, and then how we would tell you what you needed. And in the last 10 years, we're starting to realize that the conversation needs to be led by the patient and the family, and the value ladder of your experience in healthcare must be driven by what the patient and the family believe, based on their own beliefs and on their own ethnicity and on their own background and their way that they see the world. And so with that, began to see over the last few years at an academic medical center, which is a hospital at the University of Pennsylvania, giving great care and saving lives, many, many lives. But yet there seemed to be something that was missing. And from my point of view, and from a small group of us at Penn, was what is that voice of that patient and of that family? And so what we began to think of, how could we do that? How would we put that assessment, and how would we overlay that saving lives, but looking at that caring part, and came up with, we needed to hear their voice. And so that's why I came up with the Emancipation Proclamation. We have Lincoln out there now. We're celebrating the Emancipation Proclamation writing of that, and the journeys that Lincoln had to actually write that. Right. And I really see that journey parallel to what we in the industry are trying to do, as incorporating the patient and their family voice in that. So as we continue with this, needed to find someone that had that voice. And was fortunate enough to find Mary Walton. Mary Walton had been at the Children's Hospital of Pennsylvania, CHOP, as we call it lovingly here in the Philadelphia area, as the #1 children's hospital. And for probably 20 to 30 years, as Mary tells me, began to understand that you needed to listen to the parents about their children. And I was fortunate enough to recruit her away from CHOP to come with that value, and had done that at CHOP, to set up patient family center care for children, to come and help us with the adults at HUP.
What a novel idea to think that you would listen to the parents about their children. I mean, it would seem like that would be so self-evident. But again, in our healthcare systems, it isn't. It really requires breaking through. So how did you do that?
Well, I think one of the things we have to think about is we've had all these advances in healthcare. We have such specialties, such innovation and technology, that we often look at a patient's health condition or problem by their organ systems. You know, we can do wonderful things to support your kidneys or your lungs, but we forget the humanity of the person as well as their family. You know, illness is an experience and a journey for a patient and family. And so while we might need the expertise of the subspecialists and, you know, all the work that we can do in an academic center like Penn to extend life, improve quality of life, we sometimes compartmentalize and forget that there's a person. So again, thinking, and that's part of the whole perspective of nursing. We tend to look at a person in a holistic sense and realize that with your health and your wellness, your connection with your family is so important and crucial to how you would experience something. So,
you know, what was interesting is when we first, it was nursing led, when we first recruited Mary to come and help part of this, and it was really the focus of nursing. Mary knew all the contacts in patient family center care. And why don't you share a little bit about, we brought people in to do an assessment and what we found.
Right, from the Institute for Patient and Family Center Care, led by folks that really focused on the experience in pediatric hospitals, and has expanded that into adult care settings over the last 20 years.
And where is this institute located?
It's located in Washington, D.C. And Beverly Johnson is the chief officer for that. And so we invited her in to come and see where we were at Penn. And we did a lot of prep for her visit. And in her visit, Beverly Johnson brought a family advisor, because one of the key ways that you develop a culture that's really centered on the needs and values of patients is you have their voice in all aspects of the organization, not just around the individual patient's care. So she brought with her a very experienced advisor who was from a healthcare setting in Georgia. And the two of them came and spent 3 days with us at Penn, talking to our physicians, our nurses, our social workers, looking at a lot of our policies and systems and structures for care. And we did a survey of our leadership folks to see if they understood the principles.
So that's fascinating in terms of the migration of this whole concept. So it started out in pediatric hospitals primarily. It got institutionalized in this institute that is housed in Washington, D.C., but now they are like a pebble in a pond migrating out to adult acute care hospitals.
Right.
And how many acute care hospitals have they touched other than Penn? I mean, how pervasive is this?
You know, I don't know offhand. I think primarily they worked with pediatric organizations. There's three groups that have really been leaders over the last 20 years. The Institute for Patient and Family Centered Care, the Picker organization, and Plaintree. And they really have tried to work on, again, bringing the importance of the patient and family perspective to create a healing environment in an acute care setting.
Right.
You know, and I think also where we have leverage now is with the Affordable Care Act and starting to look at value purchasing, and that hospital systems are now actually going to be reimbursed or not reimbursed upon their scores with patient satisfaction. And so my guess is, Mary, and you're the expert in this, that we're going to see more and more of our hospitals looking for the concept of a patient-family-centered approach where the patient and family engagement in their voices is more powerful.
Right. They were.
Say a little bit more about that, Victoria and Mary, because I'm not sure that the average listener, person in the community, knows what value-based purchasing really means and how it will affect them directly.
Well, value-based purchasing was established in 2010 by the government, and what the idea is, particularly with CMS, which is the Medicare and the Medicaid and the federal reimbursement, is where we all know that health care costs keep escalating. And so one of the strategies are to start to hold hospital systems to tighter metrics so that you have tighter outcomes. And they're based on certain disease entities, particularly heart failure, or if you get pneumonia in the hospital, if you get an infection in the hospital. And so we're trying to have the direct consequences of being in the hospital then actually measured, and then you're based on your reimbursement from the federal government based on what you do with those metrics. Well, one of the common metrics is bloodstream infections. Many times in hospitals, almost every patient now gets an IV, gets an intravenous tube in their arms or in their neck or a variety of places. And so as the years have gone on, it's been discovered that many patients within the hospital actually get infected from those lines. And so what the federal government has done, and then started then also with the private payers, Blue Cross and Blue Shield, the variety of private payers, that there are certain metrics that you put that you're going to decrease your bloodstream infections per year, and it's going to be based on dollars, that you're able to save $2 million if you decrease a certain amount. It's almost like, for some of our viewers, if you understand gain sharing, if you're in business. And so that's called value purchasing, because it's going to be, there are certain values that we have to improve in your care, and hospitals are now going to be rewarded or sanctioned. And so what we're starting to see now with particularly the federal government, that patient satisfaction
Is one of those key
is
metrics.
one of those key metrics. So this has been slowly going over the last 5 years. And so when you look at patient satisfaction and Mary's leadership, we find out that patient satisfaction is determined by how the patients believe their care was given.
Right.
And it's really a reflection of the total experience. So I might come in and have my pneumonia treated, or I might have surgery, but did I feel as if I was treated with respect and dignity? Did I get to ask questions? Did I understand what was happening?
Right.
Was I able to participate? Was someone able to be with me during the inpatient experience?
And what we find out in the federal measures, and then if you have a variety of companies now actually do the patient satisfaction surveys that you do on a monthly basis. And I would think for many of the viewers, if you've been in a hospital system, about 2 or 4 weeks after you leave the hospital, you get a patient satisfaction survey in the mail. And so that's how we actually record those. And so that they're very important, but the keys are, did we meet your emotional needs?
Right.
Did we respond to what your voice was?
Right.
Most of the time people can measure, as if you're a non-clinician, you measure, was the food okay? Was the housekeeping there? Was there too much noise? And those things are also based on patient satisfaction. So hospitals are scurrying to look at noise and patients.
Right. But they also ask questions, you know, did your physician speak to you?
Yes.
Did the nurse answer the questions? That
Was your pain managed?
Was your pain managed, right. Well, I think that, thank you very much for that explanation, because I think it does really change the financial equation, and everybody's got a different, you know, skin in the game now in terms of how this is really going to work. But tell us about your journey, you know, to get this program in place. I mean, it's very interesting, the point that you made, Mary, in terms of, you know, all of these, particularly academic health centers, are excellent at body parts. And some people think of them as, you know, very, very high class factories. I mean, you can go in for, you know, a tune-up on your heart, or you can get a lung transplant.
I mean, it's incredible.
It is
what
incredible.
We can do.
It is. But that's the medical model.
Right.
And how were you able to overlay this nursing-driven model to get everyone's attention for them to really basically move in this direction? Was it challenging? I mean, what were some of the stumbling blocks?
Yes, it was challenging because you know, people didn't recognize that we were missing something when you get very focused and very specialized. So with the advice of our consultants who talk to folks and really looking at the literature, knowing what was needed, the first thing we had to do is we had to look at the barriers to having family presence for patients. First of all, in fact, President Obama's memorandum around this really talks about there's probably not a time when you're more vulnerable than when you're an inpatient in a hospital, whether you're in pain, you're having serious surgery. And people would like someone with them, both for emotional support, but also to be another set of eyes and ears, you know, to learn what's happening, to participate in the planning and discussion. So we had restricted visiting. And families were not always welcomed, and staff often thought it wasn't best for the patient to have them be there.
Right, I've heard that feedback.
They're in the way, or you know, they should go home and sleep, or they might bring germs into the hospital. So we really had to look at what is the importance, what's the meaning for a patient, and how could family presence really affect the safety and quality of care. So we had many discussions in helping people get out of their perspective into a new perspective about meeting the emotional needs and thinking about family as our allies to help us make a better experience, to keep the patient safe, and to have a higher quality of care. Then when we had them present...
So just to play this out, so instead of the do not enter sign, you suddenly put out a welcome mat.
Welcome, right. That
must have been a real, that's the cultural transformation piece for the staff.
Yes. Well, when our consultants walked around, you know, every area had different symbols of how welcome or not families were. And we took pictures, we used those pictures, and people were shocked when you just showed them pictures of our signage. And some areas were more welcoming. You know, thank you for being here, or, you know, do not enter, do not enter. So that was huge. And again, a lot of discussion, helping people explore it, look at the path, look at the experience from you walk in the door or pull your car up, to what it's like from a family member or the patient visiting. So getting presence was a huge step.
Right.
Now once you have the family present, how are they participating? So that was sort of the next layer of you're there and hopefully providing emotional support, but how could they help us? Could they remind us to wash our hands, to recognize that the pain management isn't working for a patient that maybe isn't as communicative as normal because of what's going on with them, to really help the staff. Who knows the patient better and longer? Family members can pick up subtle changes that maybe a physician or nurse who's only seen you for an hour might not notice.
So you were able to really swing the staff over eventually in that direction by
Yes.
giving them information, giving them a new pathway, and then showing them about this alliance, that
you
it really could help them.
But
Right.
it's a struggle, you know. It's a communication skill, and one of the things I think that was another step that Mary did is we established the Patient Family Advisory Board.
Right. They were really the three key things: presence, participation, and getting a group of experienced patients and family members as experts on the experience of being in our hospital and helping them advise us.
Right, and how did you talk about that? Because often there's a lot of resistance to doing that. You know, again, coming from maybe administration or physicians, they don't
people
want
were
people
very
in the tent necessarily.
Well, it was
That's
uncomfortable because in
Yes, it
some
was.
sense we're going to air our dirty laundry. And, you know, we don't think we have much dirty laundry, but there are certainly things we can improve upon. So there was a lot of planning before we established the role in terms of, and thinking about confidentiality. So this was a new volunteer role that we recruited. We have a wonderful director of volunteer services at Penn, and she and I worked together, and we worked with other administrative folks and our legal folks about how do we establish this new role. And then we recruited our staff, physicians, nurses, would identify patients or families that, you know, were interested in us being better.
Right.
And we recruited about 20 patients and family members as advisors. We launched our council. It's just 2 years old now. We met for the first time January 2 years ago.
That's wonderful. Tell us a little bit about the composition of that group. What kind of people were they?
Some of them are patients who say over and over again, Penn saved my life. I've had a transplant. I was critically ill. I have a defibrillator. I have a serious heart condition. You cured my cancer. We have one woman whose father received a transplant 10 years ago, and she said, I've always wanted to give back. So they all come with, again, experiences at Penn where they want to make a difference. So they come, they have significant health issues.
Right.
Many of them are using our system. Just yesterday I met one of our advisors who was there all day with his wife. She has many serious medical conditions. So he's able to really give us information about what's working well. You need to do more of this, and here's a gap or deficit that I think we can do better.
You know, from the administrative point of view, you know, administrators will say, well, what kind of difference do they make? And so Mary and her team were always challenged. But one of the advisors took on, and if you've been in healthcare, I think there's this big dark room where hearing aids and teeth and eyeglasses are. It seems like those are always lost.
The ultimate lost and found.
The lost and missing belongings.
Mary challenged, and there was
And two of our advisors took that on as a mission, and they gave countless hours and expertise, and they went to every unit in the hospital. They talked about the process for how we handle patients' belongings, particularly when they leave the unit to go to surgery.
Right.
What are systems and structures that could minimize the loss?
That's
because
great.
it has a huge impact. If you lose your hearing aid, that
is huge.
is
Or your
huge.
teeth, even
Yes,
worse.
Absolutely, absolutely.
But the power of them speaking to the staff from the patient and family point of view, it's been phenomenal. And we have them many times when patients' family come in and talk to the doctors and nurses about something went wrong.
Right.
And from their own voice, what they saw and what they felt. And little by little, the culture looks at that as something that we're going to learn from rather than you're bringing them in, the finger point at us.
Right. They want to work with us.
Right.
Right.
Well, I mean, the way you described this group, a lot of them are very grateful patients who, as you said, they really want to give something back in a tangible way. And none of these process issues of how you run a hospital, I mean, nothing is simple. You know, the policies and procedures of making sure that people don't lose vital aspects such as their teeth or their hearing aid or their eyeglasses, that takes a lot of work.
Right.
And that often, you know, sifts down to the bottom of the list of a nurse manager or, you know, even the chief operating officer. I mean, there's so many other compelling issues. So that this is a real alliance to have these grateful patients who are intelligent people who can really work in unison with the staff and come up with creative solutions.
Right, and you know, it's only been 2 years, and the first thing that everybody always talks about is the food. That was the first journey. And, you know, because you see people, you get to very concrete things.
Right.
And so we brought in the dietary leaders and had them sample
They
food.
did meal test, new menu testing.
Great.
And we wanted to order nice meals for them in the evening. They come in the evening, 5 to 7. And they said, we want the food the patients are getting. That's another way for us to see how well you're doing with improving the menu.
Did the food improve?
Yes, there's a lot of system changes to improve the meals, and we had one advisor that was very clear, you need more fiber and whole grains. You know, we want the mashed potatoes, the sweet potatoes roasted, and there's been changes. And our dietary services folks have been very active members on the council, listening and hearing, and it's hard to hear when you work that hard that things aren't.
But what I see you doing is you're smiling, so there must be some fun to this too.
Well, it is fun. Well, you know, nursing is such a fabulous opportunity to experience the human experience and with healthcare. And one of the things that's essential to a culture is always having the stories of patients and families.
Right.
So a couple months ago, 3 of our advisors who, when I interview them for the role, I hear their stories. And I love it when the stories are good, when they tell us when we're really doing well. But I interviewed them in front of about 150 nurse leaders in our big auditorium. And they told just incredibly powerful stories. But to give you an example, for nurses who, you know, really do care, one of our advisors' husband had very serious head and neck cancer. And she's an artist. She said, I don't know anything about healthcare. And I was staying the night, and she said, my husband was agitated, he had a trach, he was coughing. I didn't know what to do. And she said, the night nurse came in and put her hand on my arm and said, I'm so glad you're here. This is going to help him. And she used the word that was so empowering to me, because she said there was a sleep chair. I thought maybe I was supposed to sleep, you know? And so hearing that story helps other nurses remember. Sometimes we don't know that, you know, just taking 15 seconds and saying, I'm glad you're here, helps a family member to know how to improve.
That, plus the acknowledgement, you know, that they are on the team.
Right.
You know, they are part of the team, and that they are a vital member of, you know, this whole journey to wellness, whatever that may be for a particular person.
So for staff to hear those stories, it helps change how they see the experience. Because we certainly teach nurses about how do you handle and care for a person safely the first night post-op after major head and neck cancer. But that's another part of what they can do to really improve the care of the patient.
So we're learning. I want to share one more thing with this, is that I hadn't been to some of the Patient Family Advisory Committee meetings over the last few months. And so I went the other night to the meeting, and I guess as looking at outcomes, and I look at this two years, and I haven't even shared this with Mary, is that this was unbelievably to me heartwarming where our team is going, where they were looking at how would you help children who are of a family member that's dying. And what would be some things we could do as those children are sitting there watching their family member die? What would be things we could do with the children? And so you see us going from, we're looking at your lost teeth and hearing aids and the food, to looking at what do we need to do here to help the children. I mean, and that's showing sophistication, and talking about if you're going to have a cardiac arrest, should families be permitted to be in the room when someone's having those. So you see us looking at a very advancement of engagement with patients and families, and as caregivers, starting to be comfortable that a patient or a family member could be there if you're in a cardiac arrest, or for us to start talking to children when mom or dad or grandparents are actually passing.
That is beautiful. That is really a great story in terms of, you know, the growth and development of a program.
Correct.
I think for ending our program now, not everyone's going to be treated at the University of Pennsylvania Hospital. I mean, I'm sure you would like everyone to be treated at the University of Pennsylvania Hospital, but the reality,
our beds
are full. Okay, all right. So you're just going to have to spill over into some of the other hospitals.
Right.
What would be for our audience? What do they need to really see? How are they going to know that they're in an organization that has done the same kind of really deep organizational work that you have just described?
Well, I think if you are planning admission to a hospital, ask some questions about, you know, I want to have a support person with me. I think it often is, many patients would like someone with them around the clock to sleep at night. how will that be managed? How will I learn, and will my support person, my family member, help learn and be available? The other things that happen in hospitals are rounds when the doctors and nurses and other team members gather. I want to participate in that discussion because that's how we evaluate how you're doing, how we establish the goals, and how we're going to reach those goals. So that I want to be part of that. It's really knowing and recognizing that you're the expert in you. You need the expertise of physicians and nurses and social workers and respiratory therapists, but you are the expert in you. And if you get the sense that that's welcomed, that you're part of the team,
Right.
and you're you can make the difference by asking questions, speaking up, and recognizing that you want partnerships. This isn't about, you know, a conflict or being aggressive about anything. It's having a voice among all the members of the team,
Right.
listening and expecting that your clinical team members listen to you, and together that's a better and safer experience.
Well, thank you very much. This was really a very illuminating discussion. So I want to thank Mary and Victoria. And I just want to remind our viewers that Emancipation Proclamation actually does start with you. So ask those questions that Mary has just enumerated for you, and you will have a superior patient experience. That is something that you can look forward to if you have to be in a hospital. Thank you very much. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening, and join us again. And remember, with health, all things are possible.